Surgical Nutrition Podcast, Q&A, a comprehensive guide for general surgery residents. Welcome to today's episode of the Everything Surgery Podcast. In this special edition, we'll dive into some essential questions and answers, designed for general surgery residents and anyone interested in mastering perioperative nutrition. Pause the video when you hear the word answer to attempt the answers. Let's get started. Nutritional assessment and screening question. What is considered the gold standard for nutritional assessment in surgical patients? Answer: the Subjective Global Assessment, or SGA, which combines patient history, physical examination, and functional status. Question: which lab markers are most suggestive of malnutrition? Answer: albumin levels below 3.0 gdl, prealbumin below 15 mgdl, and lymphocyte count under 1,500/mm to the power of 3. Question: at what BMI do we start to worry about undernutrition? Answer: a BMI less than 18.5 is concerning, as it increases the risk of surgical complications like wound dehiscence and infection. Question: how significant is a greater than 10% weight loss over 6 months? Answer: it's considered severe malnutrition and correlates with poor wound healing and increased mortality. Question: can you explain the NRS 2002 tool? Answer: the Nutritional Risk Screening, NRS 2002, assigns scores, and a value of 3 or higher indicates a need for nutritional intervention. Caloric and protein requirements question: how do we calculate caloric needs for stable postoperative patients? Answer: the guideline is 25 to 30 kilocalories per kilogram per day, using adjusted body weight for those with BMI over 30. Question: what about protein requirements for post-op patients? Answer: they typically require 1.5 to 2.0 grams per kilogram per day, increasing to 2.5 gkg day for burns or major trauma. Question: does stress affect caloric needs? Answer: absolutely. Hypermetabolism due to stress can increase caloric requirements by 20 to 30%. Question: what is the respiratory quotient, RQ, and why is it important? Answer: the respiratory quotient is the ratio of CO2 produced to O2 consumed, and respiratory quotient above 1.0 suggests overfeeding and lipogenesis. Question: why do we use adjusted body weight for patients with obesity? Answer: to avoid overfeeding by calculating adjusted weight equals ideal body weight plus 0.25x, actual weight to ideal body weight. Enteral nutrition question: when should we prefer enteral over parenteral nutrition? Answer: whenever the gastrointestinal tract is functional. Enteral nutrition reduces infection risk and preserves gut integrity. Question: what are the indications for post-caloric feeding? Answer: gastroparesis, recurrent aspiration, or gastric outlet obstruction. Question: how soon should enteral nutrition be started after surgery? Answer: within 24 to 48 hours, provided the anastomosis is secure. Question: what is meant by trophic feeding? Answer: it's low-rate enteral nutrition, 10 to 20 ml/h, to maintain gut health without providing full caloric needs. Question: how do you confirm correct NG tube placement? Answer: X-ray is the gold standard. A gastric aspirate pH below 5.5 is also supportive. Parenteral nutrition question: when do we turn to parenteral nutrition? Answer: when the gastrointestinal tract is non-functional. Examples include small bowel obstruction, high output fistula, or short gut syndrome. Question: what are the osmolarity limits for central versus peripheral parenteral nutrition? Answer: central parenteral nutrition can exceed 900 mosmol, but peripheral should stay under that to prevent phlebitis. Question: how can we prevent refeeding syndrome with parenteral nutrition? Answer: start at 50% of goal calories and correct electrolytes, potassium, magnesium, phosphate before beginning. Question: what's the maximum safe glucose infusion rate? Answer: 4 to 5 mg/kg min. Exceeding this can cause hyperglycemia and hepatic steatosis. Question: why include lipids in parenteral nutrition? Answer: to prevent essential fatty acid deficiency and to supply 20 to 30% of total calories. Complications and monitoring question: what complications are associated with enteral nutrition? Answer: aspiration, diarrhea, tube dislodgement, and electrolyte imbalances. Question: how do we manage parenteral nutrition-induced hyperglycemia? Answer: use an insulin drip targeting glucose of 140 to 180 mgdl, and avoid abrupt cessation of parenteral nutrition. Question. What's the risk of catheter-related bloodstream infection, CRBSI, with parenteral nutrition? Answer. It's around 3 to 5%, but sterile insertion and maintenance can reduce this risk. Question. Why should we monitor liver enzymes in parenteral nutrition patients? Answer. Parenteral nutrition can cause cholestasis, typically seen as elevated alkaline phosphatase and bilirubin after 2 weeks. Question. What causes enteral nutrition-related diarrhea, and how do we manage it? Answer. Causes include antibiotics, hypoalbuminemia, and osmotic load, managed with fiber-rich or specialized formulas as needed. Special clinical scenarios. Question. How is nutrition handled after esophagectomy? Answer. Usually via a surgically placed jejunal tube for 4 to 6 weeks, until oral intake is safely resumed. Question. What are the unique nutrition needs in burns? Answer. 25 to 30 kcal/kg plus 2 to 2.5 grams protein kg. Early enteral nutrition reduces infection rates. Question. How do you manage high-output fistulas nutritionally? Answer. Keep the patient NPO. Start parenteral nutrition if output exceeds 500 ml day, and consider octreotide to reduce output. Question. What is immunonutrition and its role in surgery? Answer. Formulas enhanced with arginine and omega-3 fatty acids can reduce infections, especially in elective gastrointestinal surgery. Question. How do we feed patients with acute pancreatitis? Answer. Early jejunal enteral nutrition is preferred, as it reduces complications compared to parenteral nutrition. That's it. Thanks for tuning into today's podcast. If you enjoyed the content, remember to like, share, and subscribe. See you next time.